Okay. Now, this is the first two line is more than enough. The patient, 48-year-old woman, come to the office due to a 6-month history of involuntary passage of urine when she sneeze or cough. That means increase in intra-abdominal pressure. That's a stress incontinence. Is that clear, folks? Okay, so that's a giveaway here. Now, if you think it's a stress incontinence, let's see. Recently, she has experienced urine leakage even with a normal daily activity, which has been embarrassing and has caused her to limit social activities and quit playing tennis. The patient has no weakness, numbness, or fecal incontinence. Why do they think that they give this word, no fecal incontinence? Because there is another disease called what is it? Cauda-Equina syndrome on the spinal cord. Okay, that's a damage to the spinal cord. When that happens, patient has urinary incontinence and fecal incontinence. Okay, so by saying no fecal incontinence, they are giving a hint there's no spinal cord injury. Is that clear, folks? So that's one of the things, okay, keep in mind. And other than that, she says, the patient has had 4 uncomplicated vaginal deliveries. So they're giving little information on that. And that's pretty much here, folks. And then they're trying a small amount of urine leaks from the urethra when the patient is asked to cough. So they're diagnosing right there. Is that clear, folks? It's a stress incontinence. When you say stress incontinence, it's not bladder outlet obstruction. It's not urethra muscle inactivity, that's overflow. This is urge incontinence. This is overflow. This is the problem, urethral sphincter dysfunction, because perineal muscle is not giving the support for that. Is everybody clear, folks? That's the idea here, folks, okay? That's the answer here. Everybody clear with this? Okay. A 42-year-old man with a long history of type 1 diabetes comes to the office for frequent involuntary loss of urine. For the past several months, he has been having difficulty starting and maintaining a urinary stream. Because it says diabetes, folks, even though I know you might think overflow, but don't come to conclusion right away, okay? You keep it as a differential, okay? In the last 3 weeks, he had 2 episodes of nocturnal enuresis and multiple daytime episodes of uncontrolled voiding without any sensation of a full bladder. That's overflow, folks, okay? They don't even feel full, but they are leaking. Does that make sense, folks? Basically, they are not even feeling anything. That's overflow incontinence, okay, as we said. His other medical problem, there's this one. What does gastroparesis mean? The nerve to the stomach is not working. If the nerve to the stomach is not working, there's a possibility nerve to the urinary bladder is also not working. Does that make sense, folks? There you go. Now you could think it's a diabetic effect, and this is an overflow incontinence. And they're asking which of the following additional finding would be most likely present in this patient. The answer should be not this, not this, not this, not this. Increase host-wide residual volume. That's what we highlighted in the book, right? Whenever these people will come and they will say they don't have to urinate, but if you put a catheter, there will be a lot of urine inside. Okay, that's the idea, folks. All right, so that's it. It says loss of sensation in perineal area. A lot of people, that's Cauda-Equina syndrome. For you to lose the sensation in the perineal area, folks, okay? For that, they have to say some injury or trauma that happened to the spinal cord, folks, okay? Other than that, you do not pick that, folks. All right. What's the diagnosis here? She has multiple sclerosis, isn't it? If you stick to the book, you will go wrong. I ask you guys to change. Multiple sclerosis, part of urge incontinence, not overflow. Is that clear, folks? So what does that mean? What's another name for urge incontinence? Bladder hypertonia, hypertonic bladder, isn't it, folks? It's hypertonic bladder, folks, okay? Now, elevated urethral pressure, C, option C here, right? That's basically the urethral pressure. Urethra is after bladder. Is that clear, folks? So elevated urethral pressure is a good example when you have a BPH. So the prostate is compressing the urethra and the pressure is high. Does that make sense, folks? Urethra is after urinary bladder. Okay, so careful with that, folks. So here, that's the answer here. If you follow your textbook, your old first aid book, you would probably ended up in D. Does that make sense, folks? So you have to be careful. If you see the book says overflow, then you will go for large residual volume of urine, isn't it? So make sure multiple sclerosis is urge incontinence, not overflow, folks. Okay, that's that. Is everybody clear, folks? Look at that. That's why the 23% people, they actually followed the first aid. Okay, and now they fixed it on the new one, but old one. Okay, careful. All right, go for this. What's the diagnosis? So this patient, 52-year-old woman, comes to the office due to episodic incontinence for the last several months. She stated that these episodes occur almost every day and are very embarrassing. They began as an urge to urinate. Most of the time, she cannot make it to the bathroom. That's a buzzword for urge incontinence. Did we get that, folks? You don't need anything else. That concludes this is an urge incontinence. Physical exam, everything is unremarkable. Urine analysis within normal limits, okay. Urodynamic evaluation of significant for detrusor instability. So that means the detrusor muscle is randomly contracting. That's the problem here, okay, urge incontinence. So what did we say for the treatment of urge incontinence? Do you need to block those randomly contracting detrusor muscle? Is that clear, folks? So you will need to give M3 antagonist, okay. Remember, I wrote it on my picture in the bladder. We only deal with M3 and alpha 1. So you shouldn't be picking anything other than M3 and alpha 1. Okay. So antagonism of muscarinic cholinergic receptor. Is that clear, folks? That's the answer here, folks. Okay. That's it. Okay. So that's how you block it, folks. 37-year-old woman gravid at 2 paraben at 28 weeks of gestation, come to the office due to leakage of urine. The patient has had intermittent leakage with cough, but no dysuria or hematuria. So no UTI, but with cough. So kind of thinking towards stress incontinence here, folks, okay? Now she reports normal fetal movement, everything is good. 4 years ago, the patient had a spontaneous vaginal delivery, okay? The patient has no chronic medical condition or prior surgeries. Only risk factor I see, she's obese. Remember, obesity is one of the risk factors for stress incontinence. Do you see that? All right. She has gained 34 pounds during this pregnancy, okay? And urine analysis negative for any infection. So it's a stress incontinence. Did we get the diagnosis? So they're asking which of the following is the most likely mechanism for this patient's urinary incontinence. What's the problem? People with this stress incontinence, anything that increases intra-abdominal pressure, you will leak. Is that clear, folks? That is the idea here. Okay. So that's that. That's your stress incontinence. Is everybody clear, folks? Now, the last part that I wanted to mention is sometimes this might help. Nocturnal incontinence. What does that mean? People have this issue in the night when they sleep. Only that happens in urge and overflow. You should write it down. Urge incontinence and overflow incontinence will have nocturia. That means in the night can happen. But stress incontinence will never happen in the night. Yeah, unless somebody just cough and sleep, which people don't. Okay, so if a question says patient had nocturia, then you should know it's definitely not stress. So you are debating between the other two. So everybody clear, folks? So it's kind of help you to narrow down. That's all it is. People with stress incontinence would never experience in the night. Any question in incontinence? I know it's something you guys are learning without seeing the patient, but if you know this much now, when you go to rotation, you will enjoy it. Okay. Now, also remember, folks, earlier, Alice was talking about this. Some people have, not only that, most of the people have psychological thing. When there are people who sees the bathroom sign, especially elderly people, they want to go to the bathroom. Now, most of the time they are pre-diabetic, okay? Most of the time they are pre-diabetic, but they are not diagnosed with it, folks. That's one. Number two, it's a psychology. If anybody's been in obstetrics clinics, we know sometimes mother is in labor, she needs to urinate, but she cannot. What we do is we open the tap water in the labor room. And when we open the tap water, they urinate. Have you guys heard about this? So that's because when you hear the water sound, it's easy to urinate, folks, right? So
I think even they put for old people, they submerge their feet in the hot water.
Yeah, they do that. Okay, so it's all psychology, right? When you hear the water sound, and then we also do that. I don't know, it works better for females. It doesn't, because I tried to open the tap water and urinate, it didn't work. I'm just trying to research by myself. All right, folks, so that's incontinence. Is everybody clear? All right, so maybe